Good morning. This is Dr. Cindy Herndon. I'm going to be talking with you about grief and loss. And this is actually in chapter 25 and beginning with page 534. We're going to be just going over just a few pages that speak to grief and loss. And perinatal death can occur at any time in the early spontaneous, with the early spontaneous abortions, ectopic pregnancies, fetal demise at any point in the pregnancy, stillbirth or neonatal death when the infant survives for a few days. All of these scenarios can be equally devastating for the parents. The death can occur after a complicated pregnancy or when all seemed well until the baby died. Parents feel alone because many people do not consider perinatal loss to be on the same level as the loss of an older child. And friends and family might be hesitant to discuss the loss because they are afraid to say the wrong thing. Comments like, "You will not have difficulty getting pregnant again." Those comments do not usually help the parents because these comments discount the feelings that the parents are currently having. And so they're feeling devastated just as they would be if they had lost a child who had been with them longer, 6 months outside of the womb. So it's just a very hard time for them. And these are our learning objectives out of the learning objectives from chapter 25 that deal with loss, perinatal loss. And I'll let you read these. Hemorrhagic conditions of early pregnancy. Most of the time, a spontaneous abortion will be the cause of the pregnancy loss. This is most commonly due to chromosomal abnormalities that are incompatible with life. And this rate increases with maternal age, and the treatment is preventing complications such as hypovolemic shock and infection. Infection is very much a threat for this woman who has the spontaneous abortion, and also providing emotional support for grieving. This happens most often in the first 12 weeks of pregnancy, and a lot of the time the mothers have a systemic disease such as diabetes mellitus. They could have a maternal infection. They could have hypothyroidism. So some of these things are usually partially the cause of the spontaneous abortion. Bleeding in the first half of the pregnancy before 20 weeks is considered a threatened abortion. So some of the symptoms would include cramping, backache, abdominal pain, pressure and tenderness, and again, we could have a risk for infection. She could have an infection. And many times a urinalysis is performed to see if she is still, she still tests positive for being pregnant. And also beta HCG levels may be checked. But remember that the HCG levels may persist even if she has a miscarriage up to a few weeks after the miscarriage. The placenta, if the placenta is still in place to give off the HCG, even if the embryo is not present there, it will take 4 to 6 weeks for those levels to return to a non-pregnancy state or non-pregnant range. So that's important to remember. In early pregnancy loss, the treatment depends on which type of early pregnancy loss is occurring. If it is a threatened abortion, conservative treatment is usually conducted. So this is usually to wait to allow the body to go through the process of miscarrying the pregnancy naturally without medical or surgical intervention. All other types of miscarriages or early pregnancy loss may use prostaglandin misoprostol or cytotec given orally, and this misoprostol and also gemiprost, those are synthetic prostaglandins analogs that can stimulate expulsion of the embryo or the fetus from the uterus. Mifepristone blocks the activity of progesterone, which is a hormone that supports the pregnancy, as you know, and misoprostol mimics the natural prostaglandins produced during a natural miscarriage. So they can give that to induce the expulsion of the embryo or fetus from the uterus, or vacuum aspiration or dilation and curettage, or DNC, are the most common surgical methods used to clear the uterus, so either medical or surgical. Early pregnancy loss, for as far as nursing care is concerned, the nurse would provide analgesics as ordered for pain, and she would support the grief reactions that are to be expected by the mother and the father. And many times these reactions include anger, and we are to accept, as nurses, we are to accept and support the woman's emotions, because there will be high emotions during this time, depending on the woman, the woman and how she reacts to grief. So we'll talk about that a little more in the next slides. A threatened abortion is defined as vaginal bleeding before 20 weeks gestational age in the setting of a positive urine and/or a positive blood pregnancy test with a closed cervical os without passage of products of conception and without evidence of the fetal or embryonic demise. So in this case, we don't know if the pregnancy is going to be miscarried or not, because the fetus or the embryo is has not been expelled from the uterus yet. So it may keep the pregnancy, but it's threatened. So the causes of a threatened abortion may be a small fall, injuries, or extreme stress during the first trimester of pregnancy. This occurs in almost 1/2 of all pregnancies, and the chance of miscarriage is higher in older women. Inevitable abortions cannot be stopped. The membranes rupture, the cervix dilates, and the symptoms are cramping, vaginal bleeding, an open cervical os on the physical exam, but no passage of the products of conception. The intrauterine pregnancy may be either viable or non-viable when the ultrasound is conducted. Risk factors of inevitable abortion are the age of the woman, especially older than 35 years of age, a previous miscarriage, chronic health conditions such as diabetes mellitus or other health problems, uterine or cervical problems, smoking, alcohol use, and illicit drug use of the mother-to-be. This inevitable abortion usually occurs, 80% of these occur before the 12th week of pregnancy, and the other 20% of these occurs between 13 and 19 weeks of pregnancy. Pregnancy loss after 20 weeks is called stillbirth. And then we have the incomplete abortion, where some but not all products of the conception are expelled from the uterus. Complete abortion is when all the products of conception are expelled from the uterus. And then a missed abortion is when the fetus dies during the first half of the pregnancy before the 20th week, but the contents of conception remain in the uterus. And this could happen. The mom could report that she is not feeling the fetal movement, and when the obstetrician checks for the fetal heart rate. They may not hear the fetal heart rate, so then they start investigating and find out that the fetus has actually died in utero. The symptoms may include pain, bleeding, or no symptoms at all. And recurrent habitual abortions are when the mom has had 3 or more spontaneous abortions. Most often occurs due to genetic causes. It could occur due to an autoimmune cause, and it could occur due to anatomic causes such as uterine anomalies. So the uterus itself may be the reason that the spontaneous abortions continue to occur. It could be caused due to infections, infectious causes, environmental causes such as smoking, or endocrine factors such as diabetes mellitus, or hematologic disorders. So any of those things could cause the habitual abortions. And here you see 3 types of spontaneous abortions. The first one is a threatened abortion. The abortion has not happened yet, but she is having some bleeding, and the bleeding could be scant or it could be a lot. And the more bleeding that occurs, the more likely the abortion would actually happen. But some of these don't happen. Some, the bleeding might stop and she could safely carry the fetus to term. Then you have the inevitable abortion in the middle, and you see here that the membranes are ruptured and the cervix is dilated. And in this case, we know that the baby is not going to make it. The fetus is not going to be saved. It's just a matter of time. And we may have to medically or surgically remove the contents of conception, the components of conception, but they may expel naturally. And in that case, I guess that the physician would that would be the physician's call, the obstetrician's call, and time could tell about how that's going to play out. The incomplete abortion is when the miscarriage does happen, but some products of the conception have been expelled, but some remain. So that is a scenario that has to be we would have to intervene. The doctors and nurses would have to intervene on that, either medically or surgically. Disseminated intravascular coagulation, or DIC, is a condition affecting the blood's ability to clot and stop bleeding. During this action of disseminated intravascular coagulation, abnormal clumps of thickened blood or clots form inside blood vessels, and these abnormal clots use up the blood's clotting factors, which can lead to massive bleeding in other places in the body. So the causes include, during pregnancy, they include abruptio placentae, missed abortion, and preeclampsia. And so the procoagulation and anticoagulation factors are simultaneously activated. The priority in treating DIC is delivery of the fetus and the placenta. So that's the goal, just to get the fetus safely delivered, as well as the placenta, and blood replacement products and cryoprecipitate are administered to maintain the circulating volume. And of course, the nursing goals would be, the nursing interventions would be to support the health of the mother and to deliver the baby, the fetus, the embryo from the mother's uterus. Obstetrical hemorrhage, and especially DIC or disseminated intravascular coagulation, is a leading cause for maternal mortality across the globe, often secondary to underlying maternal and/or fetal complications, including placental abruption, amniotic fluid embolism, and HELLP syndrome. And we have here a link to a 7-minute video explaining DIC a little bit more in depth. So we'll listen to this in class as well, but please listen to this so you can better understand DIC. Ectopic pregnancy is the implantation of the fertilized ovum in an area outside of the uterine cavity, and 95% of these occur in the fallopian tubes. And the incidence of ectopic pregnancy is increasing as a result of pelvic inflammation. And as we know, pelvic inflammatory disease is the cause of this inflammation, PID. And we have talked about this with the sexually transmitted diseases, and we know the reason is usually chlamydia and causing scarring in the fallopian tubes, or some other infection of the lower reproductive tract reaching up to the upper reproductive tract. Therapeutic management of this is either medical management with medications or preventing severe hemorrhage and removal of the fallopian tube. And for perinatal loss, in early pregnancy loss, if the parents choose to visit with the baby, the nurse would be able to wash the baby, also apply lotion to the baby, and wrap the infant in a pretty blanket. We want to present the baby or the fetus as well as we can. Perinatal or parental grief support groups are good to recommend and to make a referral for. During this time, we would call the nurses would call the infant by name. We would try to cover the defects of the baby if there were any defects, and allow privacy for this family. And there are concurrent death and survival in multifetal pregnancies where maybe twins or triplets, maybe one triplet and ends up with fetal demise, and then the other two babies, the other two triplets would survive, or maybe it would be one twin that would pass away and one twin would still be viable. So we have those situations as well. With previous pregnancy loss, the mother is going to be very anxious, thinking that she would lose another baby, and being very anxious, especially around the time that she did lose the first baby. So do parents grieve less over a lost twin when one survives? What might their feelings be? What are their fears? How should the nurse support and advocate for the grieving parents? Well, in one scenario, we did have a mom who lost a baby at 23 weeks, and I just wanted to emphasize how important it is to know your resources in your area. For instance, there's a funeral home in St. Paul's who conducts funerals for free with babies who have, for parents who have had fetal demise. And also Oak Ridge Cemetery in St. Paul's, they have a special area where babies are buried that die early, that die before they're born, with fetal demise. Um, in this particular case, the grandfather of the baby built and crafted a baby coffin for the baby. And so the loss affects the whole family in these situations usually. And in cases of previous pregnancy loss, I said that women are typically extremely anxious along through their pregnancy up until, really throughout the pregnancy, but especially throughout the pregnancy up until the gestational age that the previous loss occurred. So they may have symptoms of depression during this time, and they are pessimistic regarding a successful outcome. Fathers may hide their worries in an effort to support the mother-to-be. Early prenatal care is especially important in these cases with previous pregnancy loss, because we want to make certain that we're doing everything we can to support that pregnancy and support that mom and the father. These couples may need more visits and longer visits because they need reassurance and emotional support. And the nursing interventions may be to give parents an opportunity to express their concerns and possibly refer the couple to a support group or even a mental health provider to help deal with anxiety and to provide a better use of healthcare resources. Nurses should note thoroughly the previous obstetrical history in regard to the previous pregnancy loss with many details prior to meeting this couple for the first time, because we don't want to overwhelm them with a lot of questions, and that we don't want them to have to relive that any more than they have to. So we want to gather all of the information that we can from previous records, and then note things before the meeting with the parents, such as the child's gender, the child's weight, the child's length, gestational age, and whether any abnormalities were noted during that loss. Also, we want to acknowledge the infant. We want to present the infant to the parents and prepare a memory box if possible. And some hospitals do have a commercial memory box that they have purchased for these sad occasions, and then they are individualized. And some of the things that they could put, that nurses can place in the memory box, might be a lock of the baby's hair, lock of the fetus's hair, maybe handprints, footprints, pictures if possible, if it's appropriate, and other things as well that they can put in that memory box. And just respecting cultural practices is an appropriate thing to do, as we as nurses try to honor all of the beliefs of the patients and the family. Emotional responses to perinatal loss are often intense, and we might refer the couple to a parental grief support group. So we need to be knowledgeable of these as OB nurses or labor and delivery nurses. And men and women grieve differently, but they both grieve. Grieving may last a few weeks, it may last several months, or more than a year. And the emotional response to perinatal loss varies individually. When acceptance and excitement about the pregnancy exists, the loss is most likely seen as the loss of a baby, not just a pregnancy. And men and women grieve differently, which can sometimes cause conflict between partners. And women tend to grieve more. They grieve more openly than men, but men report a deep sense of loss and a period of mourning. And women tend to grieve longer than men, and they also have physical changes to deal with after the loss because they are also dealing with their bodies getting back to the pre-pregnancy state. So, and the hormone fluctuation, and women are prone to baby blues anyway. So, this is a very difficult time, and we need to be very delicate with these parents, and we need to accept their grief for what it is, and just be there to support them and let them know that we are there for both of them, the mom and the dad. And as far as lifespan and cultural considerations, patients may desire to speak with a religious or spiritual leader. They may desire to have their baby baptized, and the last rites, they may want the last rites read over their child. Jewish faith is said not to allow parents to mourn or families to mourn for a child who has been alive for less than 30 days. And the Islam culture, the Islam religion believes that the child is instantly admitted into heaven. So again, it was once believed that parents of a stillborn child would not want to see their infant, or would be better off not to see their infant. So the nurses were taught to take the babies away after giving birth to a stillborn child, and they were taught that it was better if the parents did not have time with it. But now we know that this is not true for most parents, and most parents do want to see and spend time with their infant for closure. So again, the infant would be cleaned and wrapped and dressed, and the parents would have time with their infant. And the rights of the infant to be acknowledged include to be recognized as a person that was born and died, to be named, to be seen, to be touched and held by the family, and have the end of life acknowledged, to be put to rest with dignity, and allow the family to grieve in their own way. And again, if parents don't have the monetary means to give the baby, the infant, a funeral, then there may be resources in your community that you can point the parents to, or your social worker may know these resources. Non-pharmacologic therapy. For intense grief and feelings of guilt, there are group therapies available, parental group therapies, and the main idea is just for the parents to seek out a support system. Many parents may have close-knit families of support systems, but some may not. So we need to ensure that these parents are supported, and that we give them resources that they could use if they do not. And the nursing process, we want to be, as nurses, we want to take appropriate care for the parents and for the baby. This is extremely important. We need to remain patient and kind and informative. We need to explain the causative factors of the loss to the parents. And if we do not have all of the information that they desire, then we need to make a good effort to collect all of that information, or have someone to come and provide that information to the parents. The assessment of the fetal demise. The mother's communication to the nurse about the cessation of fetal movement is frequently the first indication that occurs that causes us to um, investigate her symptoms more and find that the fetus has stopped living, has that we do have a fetal demise. So safety of the mother is of utmost importance, and the fetus is also a priority. And we would inform parents of the fetal demise um, and assess the parent needs and provide resources that are needed, especially spiritual needs. We may need a pastor or a chaplain to come and speak to the parents. Um, and then also collaborate with the social worker and the grief counselor for the parents. So this is very important, and they may have their own pastor that would be called in, and family members for support. But we would need to ensure that these parents are supported. And so nursing hypotheses includes grieving, um, risk for complicated or disenfranchised grieving, risk for spiritual distress, risk for infection, risk for bleeding, and altered family dynamics. And for planning, the parents do ask questions about the loss, and we need to be ready to produce answers for them and explain to them all that we can about the loss. The client chooses how to deliver the fetus along with the physician, with the obstetrician, and they are more than likely given choices, and then they choose one of the choices. The client's health is monitored, and that is the priority, the mom's health, and the extended family or support system is available to help with grieving parents to cope with this loss. And parents express grief over the loss of the fetus and over the loss of the pregnancy, and parents avoid taking undue responsibility for fetal loss because there are many reasons for a fetal loss, and so they don't need to take responsibility for that. And we express it, we convey this to them. Usually a sign on the woman's hospital room door with something like a falling leaf or a butterfly or a rainbow is placed on the door. Just something that would let the team members in the hospital, in the labor and delivery unit, recognize that this couple has had a loss of a baby, so that they will be respectful of the couple and not say anything that would unknowingly upset the parents of this baby that has this baby that has passed away. So we would follow the protocol of the facility, and we do have a holistic focus, and we focus on the whole family. The entire team is notified, and then preparing the family for birth. Um, they would have a private room away from the laboring women on the unit, um, far away from everyone, and we would provide this family with privacy. We would maintain supportive environment, a supportive environment for them. We would stay with the mom. We would not leave her, and then enable the same nurse to stay with the couple if at all possible. And then we would give the couple time to process their grief. And then we would prepare the family for the birth. When the parents indicate they are ready, then we initiate the labor and explain what will happen in the delivery of a stillborn baby. Then provide the opportunity for them to ask questions and allow the family to make some decisions of their own. We would explain the details of the plan of care and really we would place the client in the room furthest away from other clients. Before the birth, we would establish when or if the parents would like to see the infant. And as I said before, usually it is best and they do want to see their infant and spend time with their infant. Many years ago, maybe in the 60s and the 1960s, they would carry the infant away and the mom would want to see the infant, but they would really not want her to see the infant because they thought that it was harmful for the woman to see that. But now we know that it provides a time for closure for the parents to get to spend time with their baby. So we would gently encourage them to spend time with their infant and hold their infant. And so this would enable a sense of acceptance. And we would prepare the couple for what they see before they see their baby. If there are anomalies, if there are birth defects, we would prepare them for that. And then we would cover some of that so that it wouldn't be so alarming when they do see it. It would be kind of a slow acceptance of that too, allowing them some time before they see something that would really shock them, and allow the family to remain with the infant as long as they choose, and then ask whether they would like to take home keepsakes of the child. So we talked about the memory box, so that's something that's very important. And after the birth, we ask parents again if they have questions. Again, we would provide time and space for the parents to express their feelings and carefully address any feelings of guilt. Most perinatal loss cannot be prevented. It is due to genetic problems or anatomical problems. We just don't want to place guilt on the parents, and we don't want them to place guilt on themselves. And we would promote mother's care after discharge and make referrals for grief counseling and sources of support. For the evaluation for the parents, we would ask questions about the birthing process, make preferences for birthing process known, and then express grief over loss of the baby. And we would seek to find out if the given resources were accepted to help with their grief, and develop a healthy coping mechanism to work through grieving processes. So we would encourage all of that to occur with the parents. And then I did want to just mention briefly about sudden infant death syndrome. We want to, for babies who are born, we want to really teach, do some anticipatory guidance with the parents prior to the birth of their babies to make certain that they are placing their babies on their back to sleep and avoiding overheating of the babies, using too much clothing, and also to avoid cigarette smoke around the babies, and before the baby is born, avoiding cigarette smoke. No toys or pillows or heavy blankets in the crib. No co-sleeping is advised, and parents need much support, the ones who do experience a sudden infant death syndrome with their babies. SIDS is unexplained. It is an unexplained death that usually happens during the sleep of a seemingly healthy baby less than 1 year old, usually 2 to 4 months old, and this cause is unknown, but many researchers believe that SIDS is associated with the infant's inability to arouse from sleep and to detect low levels of oxygen or a buildup of carbon dioxide in the blood. So when babies sleep face down, they may rebreathe exhaled carbon dioxide. And SIDS has no warning signs or symptoms, and they show no signs of a struggle. So potential factors that contribute to the occurrence of SIDS include inadequate prenatal care, low birth weight, premature infants, intrauterine growth delay, short intervals between pregnancies, and maternal substance use such as tobacco, alcohol, or opiates. And some research also suggests the use of substances used by the father of the baby that may be associated with SIDS. But recent research findings point to abnormalities in the 2AC serotonin receptors that are responsible for protective sleep functions in the baby. So just wanted to mention that because that's an important teaching that we do with mothers during their pregnancy and after the baby's born. And then we have some practice questions. Correct advice for women who ask about using alcohol during pregnancy is that safest if taken during the last semester, best to avoid consumption during the first 12 weeks, unknown if there is any fetal harm from its use, or important to avoid it entirely throughout the pregnancy. And so, of course, we know that it is important to avoid alcohol entirely throughout the pregnancy because we don't know how much alcohol is too much alcohol for many reasons, including fetal alcohol syndrome, but also for other reasons, such as other problems that it may cause with the baby during utero. And then a woman who had a stillborn infant at 37 weeks of gestation angrily asked the nurse why her physician did not take the baby early. The nurse should understand that the mother's behavior is unusual when stillbirth occurs this late in gestation, suggests a discord between the woman and her partner, should be expected as part of the normal grieving process, or reflects intense guilt about her own self-care during pregnancy. And the correct answer is should be expected as part of the normal grieving process. So we did say that anger is part of the stages of grieving, and so this is a normal reaction to a woman who has just lost her baby at this late 37 weeks of gestation. So she doesn't understand why that had to happen, and as nurses we need to accept her grief process and support her the best that we can. And then why is it important that both fathers and mothers be supported in the grief aspects of perinatal loss? And the answer is in your text in the purple areas on page 535, but the answers include that fathers are sometimes perceived as needing less support than the mother, and they may not receive the support they need. So we do need to support fathers as well as mothers, and we do need to give them resources that they can use to be supported if they don't have close relatives that can provide that support. And really, even if they do have close relatives that can provide support, because they may need things that the relatives cannot give them. So many fathers feel a need to appear strong for the mother of the baby, and as a result, they may hold in their grief and pain.